I think
Okay,
all the
now it's better.
presenters,
Now it's better.
yeah, better to try to present from the laptop because it's easier.
Okay.
Otherwise, it's, you face this problem. That's fine, Tirika. Now you're in the presentation mode.
Okay. So then the hereditary prostate cancer is when there are more than 3 cases in the same family, or when 3 successive generations are affected, or when more than 2 men diagnosed with prostate cancer in less than 55 years old. Other than that, we have the familial prostate cancer and the family. Then there are some syndromes, syndromic familial syndromes as well. So when it comes to hereditary prostate cancer, they have they have the early onset disease as well as aggressive disease. Then when we call familial prostate cancer, if there are more than 2 first or second degree relatives with a prostate cancer on the same side of the pedigree, that is called familial prostate cancer. Then we have other syndromic prostate cancer associated with BRCA, breast and ovarian cancer, and the Lynch syndrome. So again, BRCA 1 and 2 also more frequently associated with higher grade prostate cancer and advanced disease. And other than that, there are some environmental factors also play a role, and the dietary factors also play a role. So when it comes to metabolic syndrome and the obesity, again, it's a controversial topic. So metabolic syndrome, not merely the metabolic syndrome, mainly when the waist circumference is more than 102 centimeter, it is associated with greater risk of prostate cancer. But having said that, obesity is a controversial topic. They say in obesity, they are more prone to have higher chances of getting higher grade cancer, but less chance of getting low grade cancer. So it's a controversial topic when it comes to obesity. And again, metformin use and obesity also, there's no any proven evidence. So from that evidence, we don't metformin use of metformin as a preventive measure also not recommended. Then what about 5-alpha reductase inhibitors? Again, 5-alpha reductase inhibitors, theoretically, because it's an anti-androgen, so theoretically it should reduce the prevalence. But when we take the use of 5-alpha reductase inhibitors, it reduces reduces the risk by 25%. But there's a more chance of getting more prevalence of higher grade malignancy. So and we had to consider the side effects of the 5-alpha reductase. So considering all of this, again, it is not recommended as a preventive option. And then there are some association with the inflammatory bowel disease and balding, and the gonorrhea also associated with the higher incidence of prostate cancer. So finally, I'm coming to the topic, the screening. So screening, again, what is screening? Is a population screening. It's a systemic examination of asymptomatic people to identify the risk of a population. So where we can do some measures to reduce the mortality or measures to reduce the incidence. So mainly the measure should be the main objective of the screening program should be to reduce the mortality. And when it comes to prostate screening, we have population-based screening and the opportunity screening. And when we take the risk factors, when we take the advantages and disadvantages of screening, so we have to set a population to be screened. But it can be so there are how are you going to screen? So we can have a population-based screening or opportunity screening. So the screening can be mainly the screening is done with the DRE and the PSA examination. But there are side effects of the screening. So I will be talking the side effects after the trials. So mainly I'm going to discuss about the two trials. So when the screening say supported by the US prostate and the lung, colorectal and ovarian cancer screening trial. So this is the again multi-center randomized trial. The effect is they have selected about 776,000 men aged from 55 to 74, and it was started in 1993 and went up to 2001. And they have two control groups, the randomized group and the control group. And the main objective is to analyze the mortality after 13 years of follow-up. So in the randomized group, there was about 158 mortality, and the control group, there was about 145 mortality. So when it comes to statistical significance, in the mortality, the risk reduction, so only marginal benefit is there. So so therefore, from PLCO study, they don't recommend screening because there's no statistical significant mortality reduction from the screening. And then the other, because you can see that is the PLCO study and the screening and the control group. The screening group, the number of cases are there's an overdiagnosis in the screening group. But when it comes to mortality, again, the screening and the control group, there's no significant difference. Then the European randomized study of screening for prostate cancer, it's again randomized RCT, and they selected about aged 50 to 74 men from 7 European countries, and they followed them for 9 years. And what they found, the main objective is to see whether there is any, because they are checking the screen number needed to be screened and number needed to be treated. And then the secondary aim is to check whether the cumulative incidence of prostate cancer. And there they found there's in the screening group about 8.2% screening, the cumulative incidence of prostate cancer was there, and in the control group it was about 4.8. And they said regarding mortality in the screening group, there was about 214, and in the control group, there was about 326. So finally, there was some mortality benefit from screening, but the intention to screen analysis, the absolute difference between the screening group and the control group, 0.71 prostate cancer deaths per 1,000 men. So in order to prevent prostate cancer deaths, number of men who would need to be screened, it was about 1,410. So the number needed to be screened was high. So again, although they have had some mortality benefit, the number needed to be screened was high. So from this study, there are some mortality benefit, but again, we had to consider the side effects and the disadvantage of overdiagnosis, the diagnosing low-grade malignancy and early malignancies. And then we had to consider the side effects from biopsy, and then again the cost effectiveness. So finally, from considering the RCTs, but the EUA guideline recommends screening is associated with increased diagnosis of prostate cancer, and also associated with detection of more localized disease and less advanced disease, and no cancer-specific survival benefit was observed. And actually, we are overdiagnosing more patients, and there's no cost effectiveness. And So therefore, some centers, they recommend screening with DRE and the PSA. When it comes to American Association of Urologists, they recommend. The American Association of Urologists, they recommend screening for 55 to 74-year-old men. After, it should be a share decision. We had to discuss with the patients about the consequences of screening, because PSA is it's a organ specific but not disease specific. So we had to inform the patients, and we had to inform the patients, and it should be a shared decision. So if the patient is wishing, we can go for screening that is recommended by the American Association of Urologists. But again, the population screening and the opportunity screening is still a controversial topic. And we can, to improve our screening, yes, we can again use MRI, but again, we are adding more cost effect. We are adding more cost to the system. I think this is all about my presentation.
Thank you, Tivika. And managed to stick to time despite having some technical issues. So we move on to the question and answer session. Today's expert panel is Dr. Manjula Vijayawardena and Dr. Nishantha Lianapathirana. Let me invite the expert panel to continue the discussion on core topics of prostate cancer screening and prevention of prostate cancer. Dr. Nishantha.
Yes. Hi, good afternoon. Okay, Tivika. So let's just take the risk factors, actually the family history of prostate cancer. So if you, what do you understand by familial prostate cancer and a hereditary prostate cancer? What is the difference between them?
So there are, when there are more than 3 consecutive generations have affected, or when there are 3 men more less than 55 are affected, and there's a definition for hereditary prostate cancer. Familial prostate cancer, we are not strict. It's about within the same family. Within the same family, when more than 2 men are affected, and again, there's no age limit. So the definition is different.
Yes, so that is the technical details, but in a nutshell, when you call familial prostate cancer, that is a prostate cancer on the family. So they may have various factors, including genetic, including nutritional factors, or maybe some geographical factors, so various reasons. But when you take the hereditary prostate cancer, that is actually a prostate cancer which is directly can be correlated to a couple of genes which are sort of transmitted in autosomal manner. So, so that is the difference between them. Do you have any rough idea what percentage of them are familial and what percentage are hereditary?
I'm not sure.
Okay, so roughly around about 15 to 20% are familial, and familial could include hereditary prostate cancer also, and about 5 to 10% of the prostate cancers are considered hereditary prostate cancer. Do you have any idea on how you mentioned that the patients with hereditary prostate cancer usually have a high risk disease, and they have early onset of disease, and there's a high chance of dying and the complications? Do you know any particular reference for that? Any study? I think the
There's
data.
a study, but
Yeah, I think you had it in your presentation. There, the evidence come from the impact study. So that is where they assessed control group and a patients with BRCA1 and 2. So what do you know? What particular gene is it? BRCA1 or 2, which is associated with prostate cancer or hereditary prostate?
2, BRCA2, BRCA2.
BRCA2. BRCA2 is the one which is responsible for hereditary prostate cancer. Okay, and moving into your screening. By the way, do you know that we have national screening guidelines in Sri Lanka? But
I didn't go through this. We have.
yeah, I think the SLOUS academic subcommittee has produced a national screening guideline for the primary care. So I suppose all of you should go to the National Cancer Control Program website and search that and read about it and see what are our concerns when it comes to the local recommendation of prostate cancer screening in this country. But in globally, so we don't recommend, isn't it, the screening? So you said that the study which really recommends screening.
European
Yes.
randomized study of screening for prostate cancer.
Yes, ERSPC, isn't it? Yeah. Yeah. So this study, what is the conclusion of this study? I mean, why now this study clearly shows that there is a mortality benefit if you do the screening. But why do we not still recommend screening if somebody asks you?
Because prostate cancer actually is not a killing cancer, and there are side effects of overdiagnosis, and there are side effects of even overdiagnosis. The patient might not be symptomatic and might not die because of the prostate cancer. So still there's a higher chance of overdiagnosis, and patient has to undergo so many biopsy and the MRI, and there are side effects of the biopsy as well. And and we had to consider the patient life expectancy as well. Again health, we are overutilizing the health system as well. So we had to consider all of these factors and then come to and there's no even the mortality benefit also. Again, there's no any only one this study is showing the mortality benefit, but other than that, no, the other study didn't show any mortality benefit. And yeah, there are some limitations of having a public-based screening.
Yeah, I think when we talk about the screening, we are talking about population-based screening. So why can't we? So if somebody asks you, why can't you recommend population-based screening? Is everything what you have mentioned is basically that all these benefits are in the expense of overdiagnosis. So that is the word
Overdiagnosis
people are looking for. So at the expense of overdiagnosis, because as you mentioned, the number needed to treat was around 700, sorry, number needed to screen was around 700 odd, and to treat to prevent one cancer death.
7.14 thousand men.
Yeah. So I think number needed to treat is around 27, isn't it?
0.714 thousand men in the.
So those things are, I think, getting better and better as they follow up. But the problem is you have to prevent one cancer death, you had to screen 700 odd people. And the second thing which we would expect is that there's no proper screening tool, because the screening tool that we have is what is called PSA, and it is not very specific. And there are so many other problems because you need to bring out the Wilson-Junger criteria at this discussion if somebody asks you. So then you have to tell that there are several criteria for a successful screening program. And for that, you need to have I'll give one or two examples. Like you need to have a very effective screening tool which has high specificity and sensitivity. We don't have that in PSA, right? And of course, you need to know the disease natural natural history of the disease, and that the disease natural history has to be uniform, isn't it? But the prostate cancer is a heterogeneous cancer, and there's no natural uniformity of the disease. And there are sort of very indolent cancers, and there are very sort of aggressive cancers. So we don't know which one we are picking up with the PSA, right? So you need to bring out the number needed to screen and number needed to treat figures, as well as Wilson-Junger criteria. And that's why we are not recommending population screening, right? So that is the rationale for that. And the second important thing is what is currently happening, and what we recommend in this country is what is called opportunistic screening, okay? So, and in many other countries, including UK, they recommend age, so high-risk population screening. So there are categories for high risk. Do you know what categories are called high-risk population? Yeah.
The patients with the BRCA syndromic familial patients,
Yes.
and
yes.
Again again the familial cancer, familial prostate cancer, and
and
they
anybody
say
above 50 years of age, and
anybody who, yes,
and also Afro-Caribbean or family history of prostate cancer, right? So those are the risk factors, and those people should be offered a selective high-risk screening. Okay, right. Thank you, Manjula sir.
You have covered most. So, Devika, if you are given the chance to do opportunistic,
So I can't hear you, sir.
If you have want to do opportunistic screening in Sri Lanka, what criteria would you use? Did you hear my question?
Sorry, sir.
Yes, if you get the opportunity to do a opportunistic screening in Sri Lankan population in the urology clinic, which patients would you offer a PSA?
Sir, I can't hear you, sir. I don't know.
Did you get the question?
No, sir, I can't hear. I couldn't hear.
Okay, give me a minute.
Devika, Manjula sir is asking about if you get do the screening for opportunistic screening in your clinic, urology clinic. Who are the people you want to do opportunistic screening for prostate cancer?
So opportunistic screening, again, more than 55-year-old men, if their life expectancy is more than 10 years, and even if especially if we are going for any TURP or any intervention, and if they have any, that is one situation, or if they have any significant family members with age more than 55 years, I would recommend opportunity screening. No, I would prefer opportunity screening after discussing with the patient.
So when you discuss with the patient, what would you tell him? Now, before giving the PSA blood test, what information do you have to give to the patient? If you are doing,
I don't know, sir. I can't hear, only your.
If you are doing a screening, then you want to offer a PSA to one of the Sri Lankan patients, what would you tell him? What information do you have to give to him?
Before the opportunity screen, you ask him before the opportunity screening, what would I tell the patients? I would tell there are, because it's I had to explain the PSA is organ specific, not a disease specific. So even if if the PSA is high, it doesn't necessarily mean it's cancer. So we had to, there's a possibility of overdiagnosing, there's a possibility of undergoing unnecessary MRI and biopsy, and there are some side effects of biopsy as well. But we can still pick up cancer if it is, so there are advantages, there are pros and cons. So there are advantages and disadvantages. We might be able to pick up the cancer, but still, if we don't, there are some consequences of overdiagnosing or unnecessary biopsy, unnecessary MRI. So we had to explain the patient. So even if the PSA comes high, it doesn't mean it's cancer. So we had to correlate with the clinical finding, and we had to go for repeat PSA, sometimes unnecessary MRI. So we had to explain all these patients, all this to the consequences to the patients, and then go for a screening.
Yeah, actually that amount of information is for population screening. Because opportunistic means patient has come for a prostate symptom to your clinic. So in that case, you don't have to tell as for a normal person. Now this opportunity screening is when the patient is not having any prostate symptoms. So the information that you gave just now are for clients who are in a population screening. So in your urology clinic, if the patient is having a prostate symptom, you don't have to tell many things of what you have mentioned. You can say to complete the investigations, you do offer a PSA. Because patient has already had some prostate symptoms, that's why the patient is in your clinic.
So still, I don't, sorry to tell you, sir, but still I'm not getting you clearly. I don't know, sir, why, but the line, I can't hear you.
So Hilary will move on then. We'll move on.
Okay, so thank you very much, sir. And thank you very much, Dr. Nishantali. Yeah, so we'll move on to the next topic. I would like to invite Monipriya to introduce the next speaker and move on to the next topic.
Thank you very much for the limited to the time allocated. The next speaker will be Dr. Madhushanka Ekanayaka, Senior Registrar from National Hospital Kandy. He will talk about diagnosis of prostate cancer, PSA kinetics, imaging, and the biopsy. You have 20 minutes, Madhushanka. Over to you now.
Okay, sir. Thank you. Let me share my screen, sir. Am I visible here, sir?
Yes, Madhushanka.
Okay. Good evening, everyone, including expert panel and.
You can go to the PowerPoint sharing mode. And, yeah.
Okay.
Right. Okay.
I will be talking here with the prostate carcinoma diagnosis, including the PSA kinetics, imaging, and biopsy here. Regarding the prostate carcinoma, it's an important health problem worldwide with the aging population. And as Tivika mentioned, it's a most common malignancy and it's the 6th most common cause of cancer death among men. And incidence has risen dramatically, and that is explained partially by the use of the diagnostic modalities, including the digital rectal examination, PSA, and transsectal ultrasound use. So regarding the diagnosis, prostate CA can be suspected on the basis of the digital rectal examination and with plus or minus PSA values. But the definitive diagnosis depends on the histopathology in the prostate biopsy course. I will be talking here regarding the digital rectal examination, the PSA, then the prostate specific antigen, and the biopsy and imaging. Digital rectal examination in prostate carcinoma. The most cancers located in the peripheral zone of the prostate, and it can be detected if the lesion is more than 2 ml of volume, and 5 to 13% of risk is there with the suspicious DRA. And 18% of the prostate carcinomas can be diagnosed digital rectal examination alone. When it comes to abnormal digital rectal examination, it is associated with high Gleason scores. And digital rectal examination has usually has a poor sensitivity of around 70% and specificity about 50%. And it lacks the reproducibility. And it can over and underestimate the local extent of the disease. Digital DRE with PSA has 87% of specificity, and there is a questionable when it comes to organ confined disease. Digital rectal examination is questionable and it cannot be diagnosed. And when it comes to prostate specific antigen, as Tivika mentioned, this is a serine protease secreted by the epithelial cells, and it's organ specific but not disease specific. And it has a half-life of 2 to 3 days with a false positive results. Example in prostatitis, BPH, and instrumentation can cause false positive results. When it comes to PSA, it can be rising. It can be producing both benign and malignant prostate tissues, and it has complex and uncomplex form in the serum. PSA has a diagnostic risk stratification and follow-up values when it comes to prostate carcinoma. And when it comes to PSA variant, it increases the specificity. Traditionally, it can be categorized according to the PSA value less than 4 nanogram. They traditionally considered as a normal value, and 4 to 10 it's a gray area, and more than 10 has a positive predictive value of 40 to 72%. But PSA is not perfect test, and it has poor sensitivity and specificity, 70 to 60%. And traditional cutoff is no longer indication for biopsy. According to the EUA guidelines, PSA level 0 to 4 has a risk of prostate carcinoma. There's a spectrum that it's 6 to 27% of risk of prostate carcinoma is there, even with the 0 to 4 PSA values that is traditionally considered as normal values. And this is a diagrammatic representation of predicted probability against the prostate PSA values. Regarding the PSA kinetics and its variants, I will be discussing about the PSA velocity and doubling time, and the PSA density, pre-total ratio, and other parameters like prostate PHI and PCA3 markers. Regarding the prostate PSA velocity and PSA doubling time, here we measure the rate of change over time. Inverse is the prostate PSA doubling time. In 60 to 85 years of age, the elderly population, there is a rate of change of PSA around 0.07 to 0.27 nanogram per year, and it's age specific. Usually, we consider about more than 0.75 nanogram per ml per year increased risk of having a prostate carcinoma, but this should be done in the same lab with over period of time at least 18 months. It has a prognostic value for locally advanced and metastatic prostate carcinoma, but it has not shown any other diagnostic values in values. When it comes to PSA density, it's standardized levels in relation to the size, and average is considered at 0.12 nanogram per ml and less than that. When it comes to 0.09 nanogram per ml, it's said to be unlikely to have a PCA. And here the TRUST or MRI assessment need for the volume assessment. And here, this is a schematic representation of probability of high-grade prostate cancer versus PSA density. And it clearly you can appreciate here that the 0.15 values, above values are more towards the, it has high probability of having a high grade prostate CA. And other blood and urine biomarkers, there are various biomarkers like PHI, focus score, isomers, and other urine biomarkers, including PCA3, select MDX, and but none of them are yet recommended by EUA due to the weak evidence of diagnosing prostate CA. Regarding the imaging, I will be discussing about the transrectal ultrasound and the multiparametric MRI here. Transrectal ultrasound, usually it's hypoechoic lesion in the peripheral zones, and the hypervascularity may represent the tumor. But unfortunately, the granulomatous lesions, granulomas and infarcts and lymphoma can mimic the tumor. So the sensitivity and the specificity is very low. So it is not reliable in detection of prostate carcinoma, but it can be, it is used in biopsy and the volume assessment of the prostate disease. When it comes to the multiparametric MRI of the prostate, here the multiparametric MRI means here we use T2 weighted images, and then the MRI spectroscopic imaging, diffusion weighted imaging, and the dynamic contrast enhanced imaging for the diagnosis and the further management. Usually with the multiparametric MRI, lesions over 0.5 ml can be diagnosed. And the correlation with the radical prostatectomy specimen shows that the MRI has good sensitivity for the detection and localization of the lesions, and it is less sensitive in ISAP grade 1 lesions. So it has again useful in that sense also, and it's useful in detecting the anterior lesion. Usually the transrectal ultrasound and the normal digital rectal examination, we miss the anterior lesion. And in prostate MRI has other problems with the reproducibility because of the limits it's brought used by the non-dedicated radiologists, because our radiologists, the most of them are not used to read multiparametric MRI. And there are MRI targeted biopsies are superior to the systematic biopsy when it comes to ISAP grade more than 2. And the PROMISE study says that the false negative rate of 15%, that is half of the trust guided false negative rates, and it has sensitivity of 93%. Regarding the multiparametric MRI and its assessment with the PIRATs, usually the MRI grading are universally we grade according to the PIRATs scores. With the PIRAT 1 to 5, they are the PIRATs 3, 4, 5 are the intermediate risk, high risk, and very high risk lesions, and but the PIRATs 1, 2 are considered as benign lesions. Regarding the guidelines on the MRI imaging in biopsy in EUA guidelines, it is not considered as an initial screening tool, and they highly recommend the use of PIRAT scoring for the evaluation and interpretation, and recommends MRI before biopsies. And they positive MRI must accompany a combined targeted or a systematic biopsy. And in repeat biopsies, MRI targeted biopsy is a recommendation. Regarding the precision trial, that is, they have comparatively assessed that the MRI targeted versus standard biopsy in prostate cancer diagnosis, and it has shown that the superiority of the MRI before biopsy and MRI targeted biopsy with the standard transrectal ultrasonography. Regarding the prostate biopsy, usually it started with the initially it started with the digitally directed biopsies in 1980s, and now the standard is in the PSA era. It's a 12 core or more biopsy with the local anesthesia with transrectal ultrasound guided. Regarding the baseline biopsy decision, it depends on the PSA levels, PSA density, or digital rectal examination and imaging findings. And there is risk stratification prior to biopsy to reduce the unnecessary biopsy and unnecessary the treatment. And it's better to have MRI targeted biopsy rather than going for the ultrasound guided biopsy according to the precision trial. And that can be depends on the that can be done by a transperineal or a transrectal approach. Regarding the baseline biopsy indications, that depends on the PSA and the patient risk factors. And in a patient with suspected DRE, and the patient with symptoms and metastatic symptoms. And when it comes to repeat biopsy, usually the 20 to 30% of patients prostate carcinomas are not detected on the first trust biopsy. And if the patients have clinical suspicious of prostate carcinoma but negative systematic biopsy, initial biopsy, they recommend the MRI targeted biopsy. And other indications are the persistently high PSAs, but negative pre-biopsy, and the atypical small acinar cell proliferation, the patients with extensive intraepithelial neoplasia, and the patients with positive urinary PCA3, and the patients who are having suspicious pre-biopsy, suspicious lesion on MRI, and the patients who have been treated with ablation to differentiate the local recurrences.
Madhushanka, 5 minutes more.
Okay. Regarding the here the diagrammatic representations of the primary biopsy and repeat biopsy illustrations, where including that initially we do the systematic biopsies, and other one is that MRI and other targeted biopsies, where the transitional zone and the anterior commissure involvement. Regarding the biopsy contraindications are the coagulopathy, severe immunosuppression, and active infections. And I would, regarding the antibiotic prophylaxis in biopsy, the infections are higher in transrectal route, and the clear antibiotic prophylaxis has clear benefit against infections, and shown beneficial with the povidone iodine rectal washouts. Usually the traditional antibiotic was fluoroquine, but the development of the quinol resistant, they have there are evidence towards the cephalosporins and aminoglycoside with the target or augmented prophylaxis. The target one is the rectal swabs culture or augmented, where the 2 or more antibiotic types. Regarding the repeat and saturation biopsies, saturation biopsies are less likely to miss a significant cancer, and in all the transition zone, but it has a limited role. In the repeat biopsies, need MRI and perineal approach for the anterior sampling. Regarding the transperineal approach, patients who lacks rectum and the patient, it reduces the infection rates, and we can offer anterior sampling for missed lesions, and we can consider rebiopsy. Here we can offer MRI guided template and map biopsies. And regarding the risk of complication, it's 1% or less than that, and the fear of complication should not defer the sampling. And infections with the life-threatening infections are rare, it's less than 1%, and we have to ideally we have to swab the rectal flora, and we can offer targeted antibiotics, and there is no place for the bowel preparation. That's all, sir. These are my references.
Thank you very much, Madhushankar, for nice presentation. So we will move to experts' opinion and the expert questions regarding this topic. Manjula, sir.
Yes, Shankar. Well done for that excellent presentation. Now, suppose, let's say you're in the urology clinic and you get a patient who is 60-year-old. His first PSA estimate, which you have done opportunity screening, is 7. So how would you proceed? 7 nanograms per milliliter.
Yes, sir. I would consider about the patient's symptoms and the patient's age, life expectancy, and my digital rectal examination findings as well. And
So I'll
with
give you
all,
the digital rectal examination is normal. He's a 20 grams of prostate, and he doesn't have symptoms of prostatitis.
in the family history and the other risk factors, sir?
Well, let's say it's clear.
Given that the patient is 60 years old and patients have a PSA of 7, it's a gray area. So, sir, if the facility is available, I would go for a pre-biopsy MRI here, sir.
Why not ask for a repeat PSA blood test in about a month's time? Because
yes, sir.
before
Yeah.
proceeding
Yeah.
into a more,
Yes,
more
yes, sir.
advanced
I can offer a repeat PSA in 3 to 4 weeks, and I can yeah. Yes.
You can defer the decision to investigate further. Right. So now, how would you improve this detection of prostate cancer by the PSA alone? What are the facilities you have?
I can
the PSA as the diagnostic tool. How would you improve it?
I can go for the PSA doubling time and the PSA. I can repeat the PSA. So one thing. Then other thing is, if available, I can do the PSA in the same lab in the in 1 year time with this to see the trends of rise.
Suppose you have a very anxious patient. His PSA is, let's say, at 50 years. PSA is 4.8 nanograms per ml. Your DRE finding is normal. So he's very anxious. He has a relative who has had carcinoma of the prostate. So what would you do? You just have one single PSA study. So how would you relieve this patient's anxiety?
Sorry, sir, I'm not sure.
Yeah, then of course you can use one of these things which you said, PSA velocity, PSA density, or even prostate health index if you have the facility, right? So you can, with that one PSA test, you can try to be more specific. Okay. Now let's say you have a patient whose PSA is 7, and now you want to proceed to further investigations. So what would you recommend in Sri Lankan setting? Suppose you have got a PSA 7, next one is PSA 7.5. Now you're
ideal.
Maybe
the ideal would be the pre-biopsy MRI, but in the Sri Lankan setting, I would go for a repeat PSA, and if it is also high, I would go for a
7.5. Second one was 7.5.
Then I would go for a ultrasound guided biopsy after explaining the risk and benefits to the patients as well. And here I would consider about the systematic biopsies.
So would you request the pathologist to collect each sample to a separate bottle, or one side into one bottle?
Separate bottles.
Separate, 12 separate bottles.
12 separate bottles, yes.
Yeah, good. Right. Okay. So how would you improve your biopsy pickup of a prostate carcinoma? How would you improve it? Any
One-
steps?
One thing is, sir, I can take saturation biopsies, and I can take more biopsies, so further biopsies from the suspicious areas as well. And in the transperineal route, I can improve the and take the anterior biopsies as well, sir, from the anterior side.
So when would you decide to do the transperineal versus transrectal?
Especially in the patients who are having initial biopsy negative patients, and patients who are having MRI. If the patient initially had a MRI, if the lesions are located in areas, we can offer targeted biopsies.
So depends on your MRI location of the thyroid suspicious focus.
Yes.
Okay. Good. Nishant?
Okay, thank you, sir. Madhushankar, let's just talk about something regarding what sir has asked. So, is there any difference between PSA values in different age groups?
Yes, sir. With the use, with as I mentioned in my presentation, sir, in elderly population above age of 40 to 60, there is different age specific values.
Yeah, what are those age specific values are called? These are called Osterling's age specific PSA values, right? So that is based on a community-based assessment by Osterling, right? So you need to know the age-specific values as well as the grading, that is Osterling's age-specific values, and then you need to know the values 40 to 50 years and 50 to 60 and 60, 70 and 70 to 80, right?
Okay.
So you need to know all these values and range of those values, right? Right, and then you talked about the PSA refinements. What is the role of PSA refinement in modern day practice? When would you use refinement?
So PSA, the variants and those things are usually not for the diagnosis. It's used for the risk stratification as well as the follow-up of the patients. They have limited value in diagnosis because less sensitivity and specificity.
Do you use them for risk stratification at any point?
I'm not sure, sorry.
Yeah, so we don't use them for risk stratification per se. So as you can see, the problem with the I mean, all these PSA refinement came long time ago. And that is basically when the MRI is not so well established, the role of MRI in diagnosis, right? So nowadays we have more and more refined and high Tesla MRIs, and for the diagnosis purpose, the role of refinement is getting fade away, right? So, but as you said, the doubling time is important, and specifically, if it is what sort of lesion that you would think of PSA refinements, let's say an MRI study, what sort of lesions? Is it pyrids 1, 2, 3, 4, 5? Out of that, when would you even consider thinking of PSA refinements just to aid your decision?
Sorry.
Yeah, so if it is pyrids, yes, good. So if it is pyrids 3, so you need to know, we'll come to that. You need to know what percentages of pyrids are positive for cancer, right? So do you have any idea about the percentage values or positive predictive value of pyrid scoring system? Anybody? So because of the time concerns, you need to know these values, right? So if it is pyrids 3, roughly around, I remember it as 20% for pyrids 3, and pyrids 4, 60%, and pyrids 5, 90%, right? Those are positive predictive values. So if you have pyrids 3 lesion, around about 20% of the time, you might be having cancer. And you know what, well, these are not just cancer, these are called clinically significant cancer. Okay? Madhushankar, do you know what is clinically significant cancer?
Men with any high grade hand size is significant cancer. Any high ISUP, any high grade is a significant cancer.
ISUP 3 or above. Okay, so I'm sure
High, yeah.
about 3 and above. So clinically significant cancers, we are talking about pyrids positive. As you all know that the MRI grading system is based on clinically significant cancers, right? So if it is pyrids 3, around 20% of the time that lesion may be positive for cancer, for clinically significant cancer. So so you know that is a little bit of a lowish value, and there is a heterogeneity in reporting, as you know that there are dedicated uroradiologists. So when you decide on pyrids 2 and 3, well, some people might sort of have a little bit of hesitancy in between two of them. So there is inter-observer variance. So if you want to really aid your decision, sometimes you can apply PSA refinements like PSA density as well as PSA free to total ratio of the PSAs. So you can use it, but again, when you're using free to total ratio, do you know any cutoff value that you need to use? It should be below 10. If it is above 10, free to total ratio is getting not very accurate. Okay, right. So is Madhushankar there or not?
I'm here, sir. Yes.
Right. Okay. Right. Madhushankar, now what do you know about pyrids? What do you understand by pyrids?
It's a universal agreement of reporting prostate lesions to one thing is the communication and one thing is the reporting of the pyrids lesions.
Yeah, it's a standardized reporting of prostate MRI, multiparametric MRI. So what do you understand by a multiparametric MRI?
It's a use of combine the T2 weighted and the dynamic contrast and spectroscopic imaging to describe the lesion.
What are the components? You said T2 weighted. What else? So there's T1, right? T1 images, T1 weighted and T2 weighted. And then you have, what is the next component? Diffusion.
Diffusion weighted images and the spectroscopic images.
Yeah, diffusion weighted. And then you have what is called ADC, right? Or apparent diffusion table. I'm not 100% sure, just check that, right? And then you have the contrast
dynamic contrast enhancement.
Dynamic contrast enhancement, right? So those are the component of multiparametric MRI. Okay. So do you know what is being looked at in T1? Okay. So T1 is basically a low resolution large window. So what you are looking at is basically a large scale anatomical structures like, you know, metastatic disease in large pelvic bones, right? But T2 is a high resolution small window, right? So Do you know how do you what are the characteristics in T2 images? How would you see a peripheral zone?
It's usually characterize the water contents in
how does it appear in MRI technological jargon? So you need to know how do you name these areas. In the ultrasound scan we say echoic, no? So in MRI, how do you say the signal intensity, right? Yeah, this is hyper intense signal is there in the peripheral zone. Okay, so how does a tumor appear? So hyper intense is bright. So how does the tumor appear? Tumor appears in hypo intense image in a peripheral zone. So in a hyper intense peripheral zone, tumor would look like a hypo intense. Okay, and then the same way. And what about the diffusion weighted images? Do you know the principle of diffusion weighted images, and how do you identify a lesion there? Right, so you need to read those gaps, right? So we will we'll discuss if we have time. Okay, shall we move on to the next speaker?
Yeah. I think we are slightly behind the schedule, and there are a few other topics like Leichhardt groups and the MRI, ultrasound fusion, the elastic fusion and non-elastic fusion. Few things that trainees have to read on increasing the sensitivity of the target and all. So the next topic is going to be management of localized prostate cancer. And this will be presented by Dr. Mahendra Hera. Dr. Mahendra, are you here?
Yes, I am here, sir.
Okay. Over to you, Mahendra. You can go to the presentation view. Great.
Good evening to everybody. Today my topic is management of localized prostate cancer. Can you hear me?
Very clear. Yeah, we can hear you. Mahendra, please continue. We can hear you very well.
I can't move my slide. That's why I'm stuck.
Oh, okay.
You can't exit as well. Sir. Okay, this is EUA risk group for biochemical recurrence of localized and locally advanced prostate cancer. This is usually based on DMECO classification system, which combine clinical information on tumor extent, PSA, and pathology. And this combined with the NCCC guidelines subdivided intermediate risk disease into favorable and unfavorable group. In unfavorable features include ISUP grade 3 and no more than 50% of positive core biopsy and no at least 2 intermediate risk factors. This is EUA risk classification group, which has three group, low risk, intermediate, and high risk. In the low risk group include PSA less than 10, Gleason score less than 7, and clinically TA and 2A disease. And there's intermediate risk group. It is PSA 10 to 20 and Gleason score 7, ISUP grade 2 or 3, or clinically T2B disease. Then in the high risk group, there are two categories. One is PSA more than 20 Gleason score more than 7, that is ISUP grade 4 and 5, and clinical stage T2C, that is localized cancer. Then high risk locally advanced disease include any PSA level, any Gleason score T3, 4, or clinically positive lymph nodes. Available treatment options are: first one is deferred treatment. It is include active surveillance and watchful waiting. Then radical prostatectomy, radiotherapy, which include external beam radiotherapy, proton beam therapy, brachytherapy, then hormonal therapy, and there are some investigation therapies such as whole gland therapy and focal therapy. When come to active surveillance, it is their patient remain under close surveillance through structured surveillance programs with regular follow-up, which consist of PSA testing, clinical examination, MRI imaging, and repeat prostate biopsy, with curative treatment being prompted by predefined threshold indicative of potentially life-threatening disease, which is still curable while considering individual life expectancy. The surveillance interval are digital rectal examination yearly, PSA 6 monthly, and repeat biopsy to treat unnecessary treatment and consequently unnecessary side effect of this treatment. And it applied to a men with clinically localized prostate cancer who is having life expectancy more than 10 years or more, who do not require immediate treatment, but it delivers curative treatment when correct time to those who need it. There are no formal RCTs available comparing active surveillance to curative treatment, but recent large trial shows long-term overall survival and cancer-specific survival of patients on active surveillance are extremely good. Then the PROTECT trial, it is a randomized control trial where 1,643 patients randomized into 3 arms. One is active treatment with either radical prostatectomy, radiotherapy, or active surveillance protocol, and 56% patient had low risk disease and rest had intermediate risk. The conclusion is active monitoring was as effective as active treatment at 10 years. They have, but at a cost of increased metastatic progression risk. Then watchful waiting. It's again conservative management for patients who deemed unsuitable for curative treatment from the outset, and patients are clinically watched for the development of local or systemic progression with disease-related complaints, at which stage they are treated palliatively according to the symptoms in order to Cochrane review comparing the outcome of watchful wait to the radical prostatectomy. SPCG4 trial. It's again RCT from pre-PSA era, and it's randomized patient to either watchful waiting or radical prostatectomy, and that study found radical prostatectomy to provide superior cancer-specific survival, overall survival, progression-free survival compared to the watchful waiting at median follow-up of 23.6 years. However, the benefit in favor of radical prostatectomy over watchful waiting was only apparent after 10 years. Then pivot trial. Again, it's a RCT. It's done in the early PSA era where it compared between radical prostatectomy and watchful waiting in 731 men. Of them, 50% had non-palpable disease. But in contrast to the SPCG4 trial, it found little to no benefit of RP within the median follow-up period of 18.6 years. But subgroup analysis showed that the borderline benefit from radical prostatectomy was more marked in intermediate risk disease, but there was no benefit in patients with low or high risk disease. And there's a criticism is relative high overall mortality rate in watch and wait group. Above trial found that radical prostatectomy compared with watchful waiting reduced time to death by any cause, time to death by prostate cancer, and time to metastatic progression at 29 years follow-up. But radical prostatectomy was associated with higher rate of urinary incontinence and erectile dysfunction. Overall, men with asymptomatic clinically localized prostate cancer with the life expectancy less than 10 years based on comorbidity or age, the oncological advantage of active treatment over watchful waiting are unlikely to be relevant to them. So watchful waiting should be adapted for the such patients. This is the overall summary of active surveillance and watchful waiting. Then radical prostatectomy, its goal is by any approach eradication of cancer while whenever possible preserving pelvic organ function. It involves removal of entire prostate with its capsular intact and seminal vesicles followed by vesicourethral anastomosis. It expanded from perineal and retropubic open approach to laparoscopic and robotic assisted techniques. And the timing of surgery. There are no oncological worse outcome until 3 months delay from diagnosis to the radical surgery. Neoadjuvant treatment and radical prostatectomy. Androgen deprivation therapy should not considered as standard clinical practice, and chemohormonal when considering surgical approach. Cochrane River complained either robotic assisted retropubic prostatectomy or laparoscopic assisted retropubic prostatectomy was open RP included 2 RCT and found no significant differences between the comparison for oncological, urinary and sexual function outcomes. Although robotic assisted and laparoscopic surgery both resulted in statistically significant improvement in duration of hospital stay and blood transfusion rate over open radical surgery. So no surgical approach can be recommended over another. Then pelvic lymph node dissection. Systemic review shows pelvic lymph node dissection during radical prostatectomy failed to improve oncological outcomes, including survival. 2 RCTs also failed to show benefit of extended pelvic lymph node versus limited pelvic lymph node dissection on early oncological outcome. Extended pelvic lymph node provides the most accurate information for staging and prognosis. Then radiotherapy, external beam radiation therapy. It includes intensity modulated RT, IMRT, or volumetric modulated arc therapy, VMAT, with image guided radiotherapy. Then proton beam therapy and brachytherapy, which may be low dose or high dose. Then hormonal therapy. This androgen deprivation can be achieved by suppressing the secretion of testicular androgen in different ways. The testosterone lowering therapy, castration. Usual castration level is testosterone is less than 50 nanogram per deciliter. But current methods have shown that the mean value after surgical castration is 15 nanogram per deciliter. Therefore, more appropriate level should be defined as less than 20 nanogram per deciliter. And the available option would be bilateral lochidectomy, estrogen therapy, LHRH agonist, LHRH antagonist, and anti-androgens. Bilateral orchidectomy. Bilateral orchidectomy or bilateral subcapsule orchidectomy is a primary treatment modality for androgen deprivation therapy. It's a simple, cheap, and virtually complication-free surgery, easily done under local anesthesia. And it is irreversible, so does not allow intermittent treatment. There are no survival benefit between LHRH agonist and orchidectomy. Has been reported due to lack of high quality trials. The castration levels is achieved within 12 hours. Estrogen. This is not associated with bone loss. Has severe side effects, especially thromboembolic complication. So not considered as standard first line treatment. LHRH agonist. Long-acting LHRH agonists are the main form of ADT. Example, leuprolide. The first injection usually causes flare-up, which usually start about 2 to 3 days after administration of injection and last about 1 week. This may lead to increased bone pain, acute retention, obstructed renal failure, spinal cord compression, CVS death due to hypocoagulable state. Patient with high volume symptomatic bone disease have high risk of flare. Does not completely remove the risk. Anti-androgen and timing of anti-androgen treatment has no evidence. Long-term effect of preventing of flare is not known. Usually LHRH agonist produce castration level about 2 to 4 weeks time. LHRH antagonist. This immediately bind to the LHRH receptors and reduce LH and FSH, leading to reduced testosterone without clinical fare. The disadvantage is this doesn't have no long-acting formula. Only available is 1 monthly formula. Example are Digerelix. Then short-term follow-up data shows LHRH antagonist associated with significantly lower mortality rate and CVS event compared with LHRH agonist, but decreased libido, hot flushes, weight gain, injection site complication less often with LRH agonist than antagonist. The castration level usually achieved with 3 days. Then anti-androgens. There are 2 types. One is steroid and other one is non-steroidal. Steroidal one are the cyproterone acetate, megestrol acetate, and medroxyprogesterone acetate. Their side effects are gynecomastia, CVS, and hepatotoxicity. And non-steroid anti-androgens are nilutamide, flutamide, bicalutamide. These does not suppress testosterone. Because of that, libido, overall physical performance, and bone mineral density are frequently preserved. Both compete with the androgens at the receptor level. Then there are another treatment, androgen receptor pathway inhibitors. This is through the androgen receptors. There are several drugs which can use. One is metastatic castration-resistant prostate cancer.
Mahendra.
We can use arbitron.
Yeah, Mahendra, I think we are going a bit off topic. This is like, these are more metastatic related topics, and we are slightly behind schedule. Many more slides for you to discuss. Like in sticking to the topic today, the localized prostate cancer.
I'm coming to now. Okay, then I'm coming to localized prostate cancer. There are 3 topics under which I am going to discuss. One is low risk disease, other one is intermediate risk disease, another one is high risk disease. Then the management of low risk disease include first one is active surveillance. This is the first line treatment, and inclusion criteria ISUP1 and clinically T1CO, T2A disease, PSA less than 10 nanogram per milliliter, and PSA density less than 0.15. If these criteria were supported by detective study, and if somebody is more than 10 years of life expectancy. And extensive disease on MRI should exclude men from active surveillance, but no firm definition on this. Then factors associated with reclassification include high PSA density, 2 positive cause, and African American descent. Few histological features exclude men from active surveillance, include predominant ductal CA, fibriform histology, sarcomatoid cancer, small cell cancer, extraprostatic invasion, and lymphovascular invasion needle biopsy. BRCA2 gene testing. This is recommended for active surveillance discussion and could perform in men with family history of prostate, breast, or ovarian cancer. BRCA2 mutation does not exclude the patient from active surveillance if other criteria matched. MRI in active surveillance. In men eligible for active surveillance based upon systemic biopsy, finding alone who did not have pre-biopsy MR or rebiopsy within 6 to 12 months. It called confirmatory biopsy seems mandatory to exclude sampling error. If the prostate cancer diagnosis is made on MRI targeted biopsy alone, a confirmatory systemic biopsy should be performed before definitive decision of active surveillance to rule out more widespread cancer growth in prostate. Active surveillance change of treatment. Many men may remain active whilst they continue to consent, have life expectancy more than 10 years, and disease remain indolent. Patient preference can change treatment. PSA change should not change the management, but rather trigger further investigation according to detective conceptions with biopsy. Then alternative to active surveillance. If life expectancy less than 10 years, they should offer watch and wait policy. According to pivot and protect studies, active treatment with radical prostatectomy and external beam radiotherapy can be offered for patients with low risk disease. Radical prostatectomy and EBRT should only be considered as alternative to active surveillance in patients suitable for such treatment after thorough information on pros and cons of active surveillance and active treatment. There are no evidence supporting use of ADT monotherapy in asymptomatic men with low risk disease who are not eligible for any local radical treatment. These men should be simply be offered watch and wait policy alone. Then I come to intermediate risk disease, where patient have PSL 10 to 20 and Gleason score 7, ISUP 2 to 3 and C2B disease. And watch and wait policy for asymptomatic patients with life expectancy less than 10 years. Then again active surveillance. In PROTECT trial, 34% of patients had intermediate to high risk disease, and there was no statistically significant difference in cancer CSS at 10 years. Can consider in patient with low volume ISUP, that is less than 3 positive systemic cause or less than 50% co-involved, another single element of intermediate risk disease. Patient with ISUP3 intraductal cribriform history should be excluded from active surveillance. Monitoring schedule should be diligent given the potential high risk of progression, development of regional and distant metastasis, death of this group compared to the low risk group. During monitoring, if repeat non-MRI based systemic biopsy reveal more than 3 positive cause or maximum co-involved more than 50%, or over the core of ISUP disease, patient should be reclassified. That means actively treated. And radical prostatectomy for intermediate risk group patient offer if life expectancy is more than 10 years. SPCG4 and pivot compare the radical prostatectomy was watch and wait in localized prostate cancer. SPCG4 trial shows death from any cause, death from prostate cancer and distant metastasis were significantly reduced in intermediate risk prostate cancer at 18 years. In pivot study, a subgroup of intermediate risk group only reduce all causes mortality, but not from the death from prostate cancer 10 years. So radiation therapy in intermediate disease. Patients suitable for androgen deprivation therapy can be given combined IMRT or VMAT with short-term ADT, usually about 4 to 6 months. Low-dose brachytherapy, monotherapy can be offered with patient with NCCN favorable intermediate risk disease and good urinary function. HDR brachytherapy boost combined with IMRT, VMAT plus IGRT to patient with good urinary function and NCCN unfavorable intermediate risk group. Androgen deprivation
Shall
treatment.
we, Mahendra, I think we have, we don't have much time left. Shall we move on to the questions and the expert panels, and so then we can focus more on the questions that are asked on these topics?
Sure, sir.
Okay. Can I invite the experts to guide us through the most important questions that can be asked on this topic? Like Dr. Nishant,
Hello, Mahendra. Is it Mahendra?
Yes, sir. Mahendra, sir.
Mahendra, yeah. Okay, Mahendra. It's a bit of a daunting and big topic. So there's a huge area to cover. I understand your difficulty. So you were talking about the treatment options for localized prostate cancer, right? So, so when you're deciding on treatment options for localized prostate cancer, what is your guide?
Sir, my first, we have to ask the patient life expectancy. That's the first thing. Then we have to assess the PSA level and the Gleason score and clinical stage of the patient. Then we can categorize the patient into low.
Yes, very good. So the basis is risk stratification, and of course you need to know what is the performance score of the patient as well as his life expectancy. So risk stratification, performance score, and life expectancy. Those are the things which are very important. So then we'll talk about the risk stratification. What are the risk stratification systems that you know of about when you talk about the prostate cancer risk stratification?
So DMICO score system
Yeah.
is.
So you have shown us risk stratification like low risk, intermediate risk, high risk. What is that?
That is a DMICO score, sir.
Yeah, that's the DMICO. Do you know any other scoring systems, risk stratification systems?
NCCN risk stratification system, sir.
Okay, NCCN. What else? The other one is CAPRA. Is another risk stratification system. And what else? I think MSKCC is another sort of commonly used risk stratification system. So you don't need to know everything. You just need to know at least DMICO. And do you have any new recommendations for risk stratification? If you have read the guidelines, especially NICE guideline, have they recommended anything else in their practice? Because most of you will be going for overseas training in UK-based centers. So they are using from 2021 onward, the NICE risk stratification has been changed. You know any idea about that?
No, sir.
Yeah, so the new categorization is called Cambridge Prognostic Group categorization. So it is being applied now in UK practice. So they have divided that DMICO score main three risk categories into 5 categories. So it's up for you to read, right? So I'm not going to go into details. Based on the prognostication, so if you can sort of further subdivide them into according to mortality figures, so then you can offer much more individualized and more effective treatment by identifying further risk categories, right? Okay, right. So what is the main difference between a watchful waiting and active surveillance?
So in the active surveillance, the patients are there are standard criteria to follow up the patient, and patient's life expectancy should be more than 10 years. And when patient develops symptoms, patient should give curative treatment.
Okay, so
in what
active surveillance is where you're going to defer the treatment.
In watchful waiting, it is patient.
Yeah, whenever somebody asks you what is the core sort of idea of active surveillance is you defer the treatment to avoid the possible risk factors of the treatment. No? So possible side effects of the treatment. So you defer, but then you can at any time you can offer the curative treatment. So whereas watchful waiting is you're going to avoid treatment, yeah. And it's going to be essentially a palliative treatment that you're going to offer. Okay. So, right. The other question is, so when do you know any tools that we can decide on sort of what category of patient is having what sort of risk in their disease? Based on any practical ways of doing it other than the sort of risk stratification models?
So the gait speed test and G8 screening tool like things.
There are many online tools also, right? So for example, like ERSPC risk calculator. So you can sort of input the various sort of patients' age and family history and various parameters, and you can also, there are MRI results also you can sort of enter, and then it will give you what percentage of clinically significant prostate cancer you are harboring based on these data, right? So that is more practical way of explaining things to the patients if you have to explain before biopsy, counsel the patient, okay? Right, so what are the, so if you have a patient with localized prostate cancer, so let's say intermediate risk localized prostate cancer, what are the treatment options you can offer to him?
Intermediate and
A fit
localized
patient.
active surveillance, watchful waiting, and radical prostatectomy and radiotherapy combined with androgen deprivation therapy, sir.
Okay, so what is your preferred mode of treatment? Is it active surveillance or active treatment?
So I will, it's a active surveillance, sir.
For intermediate risk, you can offer all three, but your priority should be most of the time either radical prostatectomy or radical radiotherapy. So what are the, when you're deciding these two, what sort of things that you are going to discuss with the patient when it comes to the side effects profile wise?
In radical prostatectomy, sir, there will be urinary incontinence, sexual dysfunction.
What is the difference between urinary incontinence in radical prostatectomy and radical radiotherapy? Any values?
Can't remember, sir.
Okay, so about 50% of patients will have incontinence after radical prostatectomy, but that is the initial first 6 months. But after about 1 year, it'll be around 5%, right? So 5% of them will be having sort of permanent or very severe incontinence after radical prostatectomy. Compare that with the radiotherapy, permanent incontinence is around 1%. Okay.
Okay.
And what is the sexual dysfunction? Any idea about the sexual dysfunction between the two groups?
No statistical data. I can't remember.
Okay, right there. So, but if you do a bilateral non-nerve sparing surgery for the prostate, if you do a bilateral nerve sparing, so you have about 40% of the time you will have potency, around about 50% of the time. But if you do unilateral nerve sparing, you will have 40% of the time. Okay. So the other one is the biochemical recurrence. So, so do you know for the difference between a biochemical recurrence between the two groups? Overall survival wise, is there any difference between radical prostatectomy and radical radiotherapy based on the current studies? Usually it's comparable, right? So that would be good enough. I think Manjula sir, any other questions?
Yes, so Mahendra, now for that same intermediate risk prostate cancer patient, now you have several options. You also promoted active surveillance, and Dr. Nishant, of course, said it is surgery or radiotherapy you try to promote. So how exactly would you take a decision for treatment of an individual person? Now, consider that you're the urologist, you have done the biopsy and got the diagnosis, and you have also categorized the intermediate risk. So how would you set about selecting the best option for the patient?
First, I will see the histology, sir, whether what type of histology, whether there are.
Yes, we have now come to intermediate risk, and he's suitable for all these: active surveillance, radical radiotherapy, external beam radiotherapy. He's suitable. He's a suitable candidate.
So we want to ask whether patient is symptomatic or asymptomatic, and patient's life expectancy. And if patient's life expectancy is more than 10 years, and if he doesn't have any symptoms, patient would be offered active surveillance.
So who who would offer actually? Is it you as an individual clinician?
No, sir. We have to discuss the pros and cons with the patient, sir, and let the patient do the decision, sir.
No, actually, you have to discuss once the histology is available. All these patients has to be discussed at what is the
MDT.
occasion? Yes, you have to arrange a MDT standard, a standard MDT where experts from different fields will get together and discuss these patients' findings.
Yes, sir.
Then you all as a group will come into some options which can be offered to the patient.
Okay, sir.
That is far safer than you taking a decision and discussing that with the patient.
Yes,
Okay.
sir.
So suppose this patient has now agreed for the MDT also decided radical prostatectomy, and you can now you have facilities to do open radical prostatectomy. So what are your surgical techniques to improve the outcome? That means KO, and also to reduce the complications. What you do at the time of the operation?
There is a pre-operative.
You only have facility to do the open radical prostatectomy.
There are pre-operative and intraoperative techniques, sir. Pre-operative, I will educate the patient, sir, regarding surgery and the expected outcomes, and I will optimize patient nutrition status and give pre-operative rehabilitation with lung exercises, and there are DVT stockings, prophylactic antibiotics, and during surgery, I should have good retraction, good lightning.
Now, Mahendra, your pre-operative optimization is for like a general patient. What is specific for radical prostatectomy? Anything specific?
Pelvic exercises, sir.
Very good. So you teach the patient pelvic flow exercise, or you get the physiotherapy team to teach him pelvic flow exercise, and what else? Would you give any medication beforehand?
No, sir.
Yeah, you can consider erectile dysfunction treatments like tadalafil or sildenafil before operation.
Okay, sir.
Right. Okay. So during the operation, what are the illness specific or the technique specific things you do to improve the outcome?
So we can ligate the dorsal venous complex first and reduce bleeding, sir. Then nerve sparing techniques.
Okay, so you would try your level best to do a nerve sparing bilateral.
Yes.
Okay, that's very good. What is the next one?
The lymph node dissection, which will give some prognostic criteria, prognostic information. Lymph node dissections.
Okay.
Then the lymph node dissection.
Yeah, how would you try to improve the continence after the operation? What surgical steps would you do to preserve the continence? You'll try to do it. If you succeed, then it's very good. Patient is continent from day one.
No ideas.
You try to identify that apex of the prostate very well.
Okay.
So you try to preserve the entire external rhabdosphincter intact. When you do your division of the urethra, you try to stay at the apex so that you have a good cancer control, and also you try to save the external sphincter. So you have to really make sure that you place your division at a correct place. Now,
Yes,
during the operation, would you do a bladder neck sparing? That means you're trying to remove the prostate. Suppose the patient is not having a big median lobe. So there is another technique for bladder neck sparing. If you can do it, that will also improve the continent outcome.
Yes,
right.
sir.
Okay, then you try to minimize use of diathermy near the nerve bundles. So you use sharp instruments to cut. And what is in the post-op period? Anything to reduce the complications?
It's early mobilization,
Yeah, what do you call that that concept?
ERAS protocols.
Yeah, so you write to activate a ERAS protocol. Good. Right. So what is your idea about this? We'll move on to a different one. When would a radiotherapist or the oncologist decides on using ADT with radical radiotherapy? Any criteria?
So question not clear, sir.
No, for now say for intermediate risk patient, you have referred to the oncologist or the MDT has decided, and the patient also agrees he wants to have radical radiotherapy instead of the radical prostatectomy. Now, in what situation would the oncologist decide to use ADT and then radiotherapy and continue ADT for another 2 years, or radical radiotherapy alone?
So if a patient is having high unfavorable factors in NCC and unfavorable factors, patient will give long-term ADT, sir.
Where else?
Mm,
So what are those factors?
one is more than two intermediate risk factors criteria, sir. Other one is more than 3 cause positivity and more than 50% of co-positivity, sir.
Okay, Mahendra. Thank you. Over to you, Hilary.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Now we are going to change the direction. So up to now we discussed the topics. Now we change the direction to few selected journal articles. So there are 2 articles selected with the help of Dr. Anuruddha Abegunasekara sir. And each article will discuss 10 minutes time and the 5 minutes discussion. So with the time factor, we'll do first article and discuss about that. After that, we will decide the second article discussion. So article will discuss by Dr. Chaminda Lahakon. Chaminda, over to you.
Okay, good evening all. Can you all hear me?
Yes, Chaminda, we can hear you. We can see your presentation as well.
Okay, so today my task is to discuss about 2 journal articles. First, I will commence with this current phase of this PROTECT trial, which is published in this New England Journal of Medicine on April 2023. There they elaborate on 15 years outcome after monitoring surgery or radiotherapy for prostate cancer. When describing this article, when consider the background, so as we discuss about, so the treatment options in this localized prostate cancers include this active surveillance and radical radiotherapy and radical prostatectomy remains is controversial because this the up to date the given data is suggests that the overall this benefit same as same in the all 3 modalities. When considering this trial design, it was done at the United Kingdom, and they approved this ethics from the ethical committee, and they gathered patient from 1999 to 2009 from this community-based patients, and around 82,429 men were recruited in between the age of 50 to 69, and they all received the prostate-specific antigen. And out of them, they found that, so out of them, they found around 2,664 men with localized prostate cancer and with life expectancy of at least 10 years. And before randomization of those patients, they stratified those patients according to the age, Gleason score, and the mean of the baseline and first biopsy PSA test. And after that, they have randomized those patients into 3 groups, including this active monitoring, prostatectomy, and radiotherapy. Each group had almost nearly almost same amount of patients. When considering the outcome of this study, the primary outcome was to detect this prostate cancer specific mortality, and as well as the secondary outcome include the detection of the all-cause mortality out in those 3 groups, and as well as rate of metastasis and clinical progression, primary treatment failure, and the treatment complications. When analyzing the result, they were able to complete the follow-up of 1,610 patients, that is almost 98%. And all the data was analyzed using this data software. And when considering this risk stratification analysis, initially they thought that is more than 1/3 of those patients had intermediate or high risk disease at diagnosis. And but later this contemporary risk stratification tools such as DMECO and CAPRAS criteria, they found there's some degree of reduction of this risk groups. And considering the primary outcome, they found that there are no significant difference in prostate cancer mortality among those trial groups. The p-value was around 0.53. When considering this death from prostate cancer, so they define this death of prostate cancer by using this PLCO, or otherwise this prostate, lung, colorectal, and ovarian cancer screening trial recommendation, or this ERSPC trial recommendation. And they found there are no overall differences between 3 groups, and as well as they found that there is a prostate cancer specific survival was approximately 97% among all 3 groups. When considering death from any other causes, including this cardiovascular and respiratory deaths, they found that the similar distribution in all 3 groups. And apart from that, other outcomes, including this metastasis and long-term androgen deprivation therapy and clinical progression, they found that there are some increased incidence seen in the active surveillance group. This is the summary of this outcome. There, as I mentioned, this metastatic androgen deprivation therapy and clinical progression, you can see there is some degree of increase in the active surveillance group. When consider change of management, so usually with these patients with radical treatment groups, they almost had about more than 90% of them had this radical treatment, include either radical prostatectomy or radical radiotherapy. But with the patient with active monitoring group, at the end of this 10-year follow-up, and they found there is around 50%, 60% has to undergo any radical type of interventions. So the change of management will be there with the active monitoring group. And this is a summary of this prostate cancer survival among 3 groups. So in those 3 groups, it is almost same, and it's almost nearly about 97% with the all 3 disease protocols, disease options. When consider subgroup analysis, here they, apart from those, they analyze this death from the prostate cancer according to age and other factors as well. And they found that there's a relative risk of death from the prostate cancer differed according to the age. So by using those data, they recommend that if it is a patient is less than 65 years old, so this active monitoring or prostatectomy has lower risk than radiotherapy. But if it is a more than 65 years, the prostatectomy or radical radiotherapy had lower risk than the active monitoring. So we can use that when we are using this into our clinical practice. But when considered this PSA level, clinical state or Gleason grade group or tumor length, those things, there are no proper evidence to suggest that will change the treatment effect. Summary about the discussion of this study. So at the end of this 15-year analysis, they found that high percentage of long-term survivors in the trial population, regardless of the treatment group. So there is about 97 from prostate cancer specific death and 78 from death from any cause. And also this radical treatment reduced the incidence of metastasis, local progression, and also long-term ADT by half as compared to active monitoring. As I mentioned earlier, this active monitoring group has almost about 60% has to undergo any radical treatment later. But when considering all three treatment groups, there were no difference in the mortality at 15 years. So that emphasized this long natural history of the disease. So therefore, depending on the extent of side effect associated with early radical treatment, so including this incontinence and this impotence, so the more aggressive treatment would do more harm than the good. So again, with this, the decision should be a shared decision. And apart from that, so even though the incidence of metastasis increases, the number of prostate cancer deaths remains. Even though this metastasis increase, the number of prostate cancer deaths remain low, and interval between the metastasis and death continue to extend from 10 to 20 years in some cases, usually in the active monitoring group. When considered site of metastatic disease, usually this local regional lymph node involvement is comparatively high in the active surveillance group. But when considering this visceral and distant lymph node involvement, also similar in all three groups. And interestingly, that skeletal metastasis usually low in the radiotherapy group. That is most probably due to this neoadjuvant ADT treatment that would address on the micrometastatic disease, which is not used in the active surveillance of the radical prostatectomy groups. When consider this change of management rates in this trial, also similar into the other trials, there is 30% of patients undergoing either prostatectomy or radiotherapy within 3 years. When comparison with the other studies, so these include this pivot or the Scandinavian prostate cancer group study, they instead of active surveillance, they use this watchful waiting, but the findings were much more similar. But however, those studies found another thing, that is a suggestion of age effect that was not seen in the pivot or this Scandinavian prostate cancer group study. When considered the limitation of this study, since its inception, the treatment and diagnostic methods has evolved because it's a long time. It was started in early 1999, and even with during this recruitment of patient, at that time investigators usually didn't use this contemporary multiparametric MRI or PET scan combined with the PSA, and also they haven't done this biopsies with image guidance. Considering the strength of this trial, so this trial is done in this more generalizable population. They recruit the patient from this normal generalized population from the clinic, and from there they identify the this localized prostate cancer, and they use this proper randomization protocol. So it has a good randomized comparison. And apart from that, it has a standardized treatment pathways as well as sustained high rates of follow-up. So from this trial, so this findings provide that necessity of great awareness regarding the limitation of current risk stratification methods and treatment recommendation in the guidelines. And also, many newly diagnosed localized prostate cancer and their clinician can take time to careful consideration to take off between harms and benefit of treatment when making management decisions. So that is the end of this first journal articles.
Thank you very much, Chaminda. You are stick to time, and you have prepared a very nice, attractive presentation with this journal article. Now is time for discussion.
Chaminda,
Yes.
so you mentioned about the PROTECT trial. So when you talk about surveillance, or let's say screening, what inferences that you can get from the screening with the PROTECT trial?
So I didn't get the question.
Yeah, so let's say, can you make any recommendation based on PROTECT trial about prostate cancer screening? Will it help, or will it support screening, or will it post screening?
The thing is that this shows that there are no major overall difference between this management strategies. So this active management doesn't doesn't have any really difference with the monitoring.
Yeah.
So, apart from that, other thing is this sub outcome, that is age related prostate cancer management. So, but I don't think it has given any things related to the screening.
Monitoring group. So even if you sort of, these are like, when you pick up these patients, you have to sort of pick them up out of the screen population, isn't it? PSA screening. So the entry criteria is DRE and PSA, isn't it? So if you select them by doing DRE and PSA, and then you assess them with the sort of control group, even the active surveillance, I mean, even if you just monitor them, right? And if you do some active treatment, it hasn't made any difference for overall surveillance, isn't it? Survival, isn't it?
Yes.
Example that even if you don't screen them, overall survival won't be any difference. So that is one of the sort of opposing counter argument for generalized screening and selecting people and then managing them, right? Because overall survival is not going to be much of a difference. But then again, as you said, the subgroup analysis, there are many factors that you had to mention. Manjula sir, any comments?
Yes, so I heard Chaminda, you're saying 60% of the active, 60% of the active surveillance group, when it comes to 15 years, change to a radical treatment option. Is that correct?
Yes, sir.
At 15 years?
Yes.
So that means by doing the active surveillance, that 60% were postponed of their side effects for some time. Because if they were offered the radical treatment at the beginning, they would be suffering with the side effects till this date of decision, the
Yes.
subsequent date of conversion. So you would roughly know how many years in average those patients escape the side effects. No?
Actually, I didn't know, so I didn't go through that.
Because at 10 years, it is 50%.
Yeah, and
Then at 15 years, it is 61%. No?
yes, sir.
So at least half of the active surveillance group managed to stay off the side effects for 7.5 years.
Yes.
Okay, right. So now in your clinic or at your MDT, there is a patient who is less than 65 years. And now MDT should be promoting active surveillance or active treatment. Suppose there is a patient who's in
So in that case, active surveillance should be promoted because he's already 65 years. So it will take around another 15 years to develop this conversion of this active surveillance into a radical treatment.
Yeah. So for a less than 65-year-old,
Yeah, in that
what
case,
is MDT promoting? According to the PROTECT trial, who should you promote?
yeah, in the PROTECT trial, so this less than 65 years, usually they recommend this form of radical treatments. In that subgroup analysis, they shows that this less than 65 years, better to go with this either with the radical treatment rather than the active surveillance.
Okay, Swami. Thank you.
Thank you very much, sir. So, shall we move to the next journal article also? We are running behind the time, but I think we can consider the next article as well. Another 15 minutes.
So go ahead.
Right. So, Chaminda, shall we move to the second article discussion? Sorry, presentation first. Yeah.
So my second article so in the as of my second article, I am going to discuss about this analytical study which was published in this British Journal of Urology International, where it is a performance of prostate health index and prostate this PSA density in a diverse biopsy naive cohort with multiparametric MRI for detecting significant prostate cancer. And this was published in 2021. And when consider this background, so as we have described initially in our presentation, the PSA testing, so though it is improve the detection of prostate cancer and also though it is reduced the prostate cancer specific mortality, but with this its poor specificity in detecting clinically significant lesion group grade, which will result in over detection and over treatment of indolent prostate cancer. So due to those reasons, this other things including this PSA kinetics and other things has evolved. And apart from that, with this imaging, so this multiparametric magnetic resonance imaging, so we can combine both for increase this identification of lesions, this clinically significant prostate cancer, and as well as it will give additional benefit of doing this targeted biopsy as well. And but the limitation of this MRI would be that so it might miss about 24% of clinical significant prostate cancer, especially when it comes into this pilot 3 less than pilot 3 lesions. And so when discussing about this outcome of this study, so the main objective of this study determine the utility of this prosthetic health index and PSA density in the series after multiparametric MRI, improving the accuracy of detecting lesion group grade 2 to 5 prostate cancer and thereby improving the specificity in multi-ethnic population. So additionally, they have focused on the impact of biomarkers in these pilots 1 to 2, 3, and 4 to 5 lesions. And they recruited the patient from February 2017 to February 2021. Around 143 men were included. The selection criteria was age between 40 to 79 without having any previous prostate biopsy. So they have excluded the patient with history of previous prostate cancer, men with signs and symptoms of infection or prostatitis, or patients who are taking 5-alpha reductase inhibitors. And meantime, they did this participating urologist from the DRE and all the men, and they classified that as a normal or suspicious. So all the patients who underwent, who recruited this study underwent the multiparametric MRI, and then the lesions were assigned from the score from 1 to 5 based on the standard this pilot's criteria version 2. But during the analysis, they considered 5 as 1 and 2 lesions as a negative, and from there onwards, 3 is equivalent, 4 and 5 lesions as highly suspicious. There is something about that pilots category, so initially we discussed. And all the recruited patients, regardless of the pilot score, all of them underwent this prostatic biopsy. If it is pilot 3 or 5, they underwent this MRI guided fusion biopsy, and if it is less than pilot 3, they underwent this ultrasound transrectal biopsy, ultrasound guided transrectal biopsy. And the pathological assessment of this biopsy was performed by 4 expert uropathologists, and primary outcome was to identify lesions grade 2 to 5 prostate carcinoma on the biopsy. And all the patient underwent this prostate health index and the PSA density assay. So they are in this prostate health index, we use this PSA and free PSA, and as well as total PSA and the pro PSA level, and that was mathematical formula which will identify the prostatic health index. So then they did the statistical analysis. They used this for the data analysis. They used this they use these logistic regression models to generate receive operating characteristic curves and the area under the curves with the 95% of confidence interval. So during their evaluation, they compare with this low PSA digital rectal examination finding that is suspicious, so normal, and the pilots as well. There are different models they have used. When considering the result, so the patient that recruited there are about 143 men, and apart from that, they included both white and black, so there is some racial comparison as well, and the median age was around 62 years. And compared with this white and black men, they found that there is some BMI, PSA, and PSA density has significantly higher median in the black men. When considering the result, they found that combined both pyrites and the log of this prostatic health index with the base model, and there will be this area under curve increase of 0.81, and further in this race, either black or white, such model will increase this area under the curve of 0.84. which is statistically better than the base model, along with the prosthetic health index. These are some summarization of this result. And when it goes into the discussion, so this analysis showed that this prostate health index and the PSA density and pyretes are independent predictors of Gleason grade group 2 to 5 prostate cancer in biopsy naive patients. And apart from that, this black trace was an independent predictor of this type of prostate cancer, but they did not modify the effect of prostate health index, PSA density of pilot score. And during this study, they found that this clinically significant Gleason group 2 to 5 disease were found about 6 within this PIRATS 1 to 2 group, but interestingly, all those patients were in the black participants. When considering this PIRATS 3, where this is somewhat gray area for the disease management, so a lot of most of the time those patients undergo sometimes unnecessary biopsy. So this study demonstrated that when this prostate health index is used as a serial test for the PIRATS 3 lesion, that prostate health index threshold, if it is more than more than 49, that might avoid the unnecessary biopsies in 55% men without missing any this clinically significant prostate cancer. So those are this area and the curves with increasing grade group 2 to 5 prostate cancer from logistic regression models. Both left side one shows this along with the PHI score, and other one is the PSA density. Both show that they are a positive value. When compared with the other studies, this was done at the United States, and there were no other data in the United States apart from this. But when there is a study with this Naganaprasanam et al., he assessed this prostate health index in a cohort of men undergoing repeat biopsy and reported that adding PHI will improve the overall and Gleason grade 2 to 5 prostate cancer detection by using this area under the curve. So as a conclusion here, this prostate health index and the PSA density and multiparametric MRI of the prostate are independent predictors that aid in the detection of Gleason grade 2 to 5 prostate cancer in the biopsy naive prostate biopsy cohort. And apart from that, this prostate health index is a particularly useful in men with equivocal PIRATS 3 lesions. So especially with this PIRATS 3 lesion, this is very useful. And we can safely avoid over 50% of unnecessary biopsies. And it is superior to the PSA density in regard. When considering the limitation of this study, the sample size of this study is relatively small, only 143 were included. And the recruited patients are usually referred by this tertiary or publicly funded medical center. And this included only black and white men, which may limit the generalizability of the result to men to other races, including the Asian and Caucasian countries. And they also not powered for race stratified analysis. And also could have missed some men with Gleason grade 2 to 5 prostate cancer by not directly targeting all the PIRATS 1 to lesion and the prostate biopsy. As in the PIRATS 1 to 2 lesion, they use this ultrasound guided transsectal biopsy apart instead of any other imaging modality. So that is all about the discussion, and thank you.
Thank you very much, Jaminder. Stick to your time. We'll move on to the paper discussion now.
Jaminder, thank you. That was very excellent presentation. So I have the same question as Dr. Nishant asked for you in the other paper. Would the knowledge gathered from this paper is for screening, PSA screening, or of the general population or not?
Yes, they consider this PS it is against for this screening purpose, because they found that there is a increase of detection of indolent cancer with the PSA, doing the PSA for a screening test, and that might go lead for this unnecessary treatments. And but if we are using for the opportunistic screening, yes, in that case we have to combine with this more sensitive this PSA variant such as prostate health index. So
Okay, so that I didn't get the answer I was expecting. Anyway, now to do a prostate health index, would this existing PSA measurement be sufficient, or do you have to have another type of a test to get the PSA value?
yeah, what they use is this. They measure this total PSA, free PSA, and as well as they want to measure this pro PSA levels. By using those, they mathematically.
Yes, you need another immunofluorescence test to detect that one.
Yes.
Yeah, okay, right. Thank you. Nishanta?
Sorry. Yes, Chaminda. So, so you mentioned about prostate health index. Apart from that, and also the PSA density, what is the difference between these two tests and Progensa test? You know what is Progensa? Progensa is PCA3 antigen test. So what is in application wise, what is the main difference? So this is going to be mainly used, as you said, in many instances, to decide on assessing whether you need to sort of biopsy a Pirates 3 lesion. Is that right?
Yes.
Yeah. So would the PCA3 has the same application, or is it different?
Yes, I doesn't have any idea about that. I didn't read about that.
Yeah. Okay. Yeah. I think, well, none of these things are recommended in guidelines. So in guidelines, they haven't still accepted that PHI or the prostate PSA density to be a criteria to sort of decide a biopsy, because simply they don't want to miss any cancers. So as we discussed earlier, Pirates 3 is a bit of a very kind of a gray area, because whether you decide a Pirates 2 or 3 is mainly depending on your expertise of your interpretation, and dedicated radiologist might consider something 3, so vice versa, right?
Yes.
Because of that, to be on the safe side, guideline always say if it is Pirates 3, you biopsy without doing any further testing. Because we said, as we discussed, around about 20% of the cases will have sort of clinical significant prostate cancer. Whereas PCA3 is used in many instances where there's negative biopsies for Pirates 3 or maybe any other Pirates lesion. If there are, if a single MRI targeted biopsy is negative, you can use PCA3 to decide whether there is a need for a sort of, you usually recommend another biopsy, but if it is repeated negative biopsies, it's an anecdotal sort of help to decide to go for another one. Okay. You have any other tests in the literature which can be used or which is used in sort of more used in the current day? There is a test called Control MDX, again, it doesn't check any prostate cancers, but it's a kind of a genetic test which tests epigenetic changes of the biopsy tissue, because around the prostate cancer, it is being commonly identified that there are various sort of epigenetic changes occur in the BPH tissues. So to detect them will increase the chance of or increase the suspicions of presence of prostate cancer. So that's another test to read. So yeah, I think those are the things I wanted to highlight. Thanks.
Right. Thank you very much. Before conclude the today's Uromet 2.3, the prostate cancer one, let me thanks all the presenters, and experts, Dr. Manjulu Vijayawardena and the Dr. Nishanta Lianapatirana, and all the participants today's Uromet session. And we have to thanks the making this event success, the SLAUS Academic Committee, as well as the sponsors, the Cipla Pharma. So we think we can meet in next Uromet 2.4, that is in next Saturday, 10th June, with the prostate cancer 2. In there we will discuss locally advanced prostate cancer, metastatic prostate cancer, and drugs used in prostate cancer, and a few articles as well. So thank you very much for everybody participating in Uromet today's session. Thank you.
Thank you, sir.
Thank you, sir. Good night.